Another case.
Next, I'd like to introduce Dr. Mohamed Hamdy, Cairo University. He will talk about dilemma of chronic abdominal pain.
Thank you, Professor. Assalamu alaikum wa rahmatullah. Good evening, my dear professors and colleagues. It's my honor to present our case dealing with a dilemma of chronic abdominal pain. Let's start with our patient, who is a 32-year-old female patient who was born and living in Giza, and she's married with 2 offsprings. The youngest is 3 years old. She's a housewife with no special habits of medical importance. She presented to us complaining of a long-standing upper abdominal pain that was of 6 years duration, with insidious onset and progressive course. The pain is mainly epigastric, dull aching with no specific radiation. It was aggravated by meals and relieved during fasting. So H. pylori antigen in stool was done and diagnosed as H. pylori gastritis, for which medical treatment was prescribed with successful eradication of H. pylori. However, her abdominal pain is still persistent with the same features. There was no history of vomiting, no history of diarrhea, bleeding per rectum, or constipation. There was no history suggestive of autoimmune etiology as oral ulcers or joint affection, no history of fever, and review of other systems was unremarkable. Regarding her clinical examination, she had normal vital signs in the form of blood pressure, pulse rate, respiratory rate, and temperature. Also, there was no significant physical findings noted. Her body mass index was 20.1 kilogram per meter square. Her body weight was 51.5 kilograms and a height of 160 centimeters. So our problem list in brief is long-standing epigastric abdominal pain exaggerated with meals. What should we think about in this case? In brief, the differential diagnosis of chronic upper abdominal pain could be one of chronic cholecystitis, functional biliary pain, sphincter of Oddi dysfunction, primary sclerosing, Budd-Chiari syndrome, chronic Bertel von thrombosis. Also, we can consider cardiopulmonary disease, peptic ulcer disease, GERD, dyspepsia, gastritis, chronic pancreatitis, or splenic affection as splenic abscess, splenic infarction. On the other hand, we should consider IBS, IBD, celiac disease, chronic mesenteric ischemia, hypercalcemia, hypothyroidism, or celiac artery compression syndrome. So we proceeded for our investigations. Basic investigations of blood picture showed a normocytic normochromic anemia with normal leukocytic counts and platelet count. Her liver profile was almost normal. Also, her kidney functions and electrolytes were within normal range. Her lipid profile also is normal. And regarding her fasting blood glucose, sepsis markers, and TSH were also normal. We proceeded for a pelvic abdominal ultrasonography, and it showed a normal study, normal liver, spleen, gallbladder, and other intra-abdominal structures. The next step was upper GIT endoscopy, where we found the esophagus with few linear erosions at the distal end. Regarding the stomach, the mucosa of the fundus and body was normal. The mucosa of the antrum is hyperemic, from which antral biopsies were taken for histopathology. The first clue to our case was in the duodenum. The bulb was normal. However, the lumen of the second part is seen partially compressed with visible pulsation of the posterior wall that may suggest superior mesenteric artery syndrome. Also, biopsies were obtained from the distal second part to exclude celiac disease as a differential diagnosis. And the result of the biopsy was mild duodenitis with preserved villi, chronic inactive gastritis of mild intensity and indefinite for H. pylori. So it was non-conclusive. The diagnostic challenge, what's next? In this patient, we proceeded for a color duplex of the abdominal vessels that showed a patent upper abdominal aorta and patent superior mesenteric artery. However, the celiac trunk was patent but curved. During fasting, there was an increase in the peak systolic velocity and in diastolic velocity that showed marked increase postprandial, where it reached 181 centimeters per second for peak systolic velocity and 63 centimeters per second for in diastolic velocity. And the curved course included mild stenotic lesion, 2 millimeters after the mouth, causing 48% diameter stenosis with mild post-stenotic ectasia. So, we proceeded for a multi-slice CT scan of the mesenteric vessels with contrast media, and we had the following picture. The celiac artery origin shows mild osteoproximal king concave uppers with acute angulation curvature and mild post-kinking dilatation. So the conclusion was a picture suggestive of median arcuate ligament syndrome. What is median arcuate ligament syndrome? It has other synonyms as celiac artery compression syndrome, Dunbar syndrome, and is more likely to affect young adult females, which is consistent with the demographic characteristics of other chronic abdominal pain patients. Its signs and symptoms are commonly upper abdominal pain that frequently made worse with eating, weight loss, nausea and vomiting, upper abdominal berea. Other associated symptoms could be present as palpitations, chest pain, diarrhea or constipation, and difficulty sleeping. The causes of abdominal pain in such a syndrome may be due to one or a combination of more than one of the following hypotheses: either poor blood flow from the celiac artery compression, nerve irritation from compression of celiac nerve plexus, or a steel phenomena, where blood flow coming from another abdominal vessel at the superior mesenteric artery could supply the stomach and liver during eating and cause pain. The nerves in the area of the celiac artery are thought to be overstimulated, leading to arterial spasm, and compression of the nerves causing interference of the neuroenteric pain pathway, leading to hypersensitivity and pain. To reach a diagnosis on such a case, we have to follow a sequence of workup because there are many patients with celiac artery compression and no symptoms, and because there are many causes of chronic abdominal pain. So the sequence of workup should start with blood work and inflammatory markers. Then we proceed for abdominal ultrasound, followed by upper endoscopy with biopsies to exclude IBD and celiac disease. The next step is mesenteric duplex ultrasound, where we can reach a possibility of diagnosis when peak systolic velocity is above 200 centimeters per second and end diastolic velocity above 55 centimeters per second. And to confirm our diagnosis, we should proceed for CT mesenteric angiography or MR angiography. The differential diagnosis in such a case for such a patient is to exclude other causes of abdominal pain as functional dyspepsia, abdominal migraine, irritable bowel syndrome, and rumination syndrome. Regarding the treatment, we have surgical release of the celiac artery from compression together with simultaneous removal of the nerves that are being compressed. Average success rate of being symptom-free following surgical intervention is reported to be 60 to 80%. However, in case of recurrence or persistence of pain, re-evaluation for possible re-narrowing of celiac artery should be performed in the following sequence. In case of recurrence or persistence of pain, we should repeat the mesenteric duplex ultrasound. When we find a normal celiac artery velocities, we should proceed for CT angiography to detect intra-abdominal pathology. If exists, for surgical resection. If no lesion is existing, we should proceed for celiac plexus nerve block. On the other hand, if there is still significantly elevated velocities, we should proceed for angiography and possible angioplasty. What about our patient? The patient underwent a laparoscopic surgical correction with division of the median arcuate ligament and release of the celiac artery compression, as we can see here. The figure B is showing a laparoscopic division of the median arcuate ligament, and the celiac stenosis and post-stenotic dilatation is shown by the arrow. In our patient, the patient is now pain-free with good appetite and normal lifestyle. Thank you.